in our casualty, a 64-year-old lady has come to us with 3 days of increased urinary frequency, some worsening confusion, and also had a fall on the same day prior to presenting to us. She's a known diabetic and a hypertensive. She's had past ischemic stroke. She's had seizures on antiepileptic medication, and she has mild cognitive impairment. So as the ED physician, we are being asked to see her. She has a temperature of 100.2 degrees Fahrenheit, and her blood glucose on examination is 360 milligram per deciliter. So we feel that a urinary tract infection is likely, and we are doing a urinalysis. And on the results for urinalysis, we find that the urine nitrites is positive, but the remaining part of the urinalysis is unremarkable. That means there is no pyuria, no leukocytes, no blood, no protein. The rest is normal. So we are concerned, and we feel that maybe she does not have a UTI, maybe something else is going on, and we are hesitant to start antibiotics. But the medical student who is observing us feels that they are saying that I thought nitrites was diagnostic of a UTI, so shouldn't we be starting this patient on antibiotics? So this is the question that they are faced with. So to answer this question, let's look at the study which looked at the validity of urinalysis and microscopy for detecting urinary tract infection in the emergency department. So we are hoping that this study will answer our question about how likely it is that this patient has a UTI. So this is the rough outline of how we go about the critical appraisal of a diagnostic test. The first one is, as usual, how serious is the risk of bias. So we look at how this test was, how the study was conducted. Then we look at the results, and then finally we look at how we can apply these results to our patient. Here in this study, they looked at female patients between the ages of 18 to 65 with a triage diagnosis of urinary tract infection, and they did this urinalysis test, and we are specifically interested in these two things. First one is urine for nitrites, and the rest is for blood, protein, and leukocytes. And we compared that with the gold standard of urine culture growth of pathogenic bacterium at the end of 2 days, at the end of 48 hours. And then the main outcomes we were looking at were the likelihood ratios, which we'll be looking at what they are in subsequent slides. Also the sensitivity, specificity, the positive and the negative predictive value of the test. So this is the test. They used a calorimetric diagnostic test, an effort test, glucourinalysis. It's a simple strip test. So the strip should be dipped in urine for 120 seconds, and then the colors have to be interpreted based on the supplied color chart that was given in the test. So they have also given us the approximate values for everything, which is 0, plus, 2 plus and 3 plus. So based on the colors, we can interpret whether it is 0, 1 plus, 2 plus or 3 plus, and what are the approximate absolute values for that. These were also given to us in the interpretation of the test. So now we move on to how serious the risk of bias was. So did participating patients present with a representative sample of those presenting with a diagnostic dilemma? So this has to do with when we are doing a test, if supposing we feel that this patient, if we have a patient in front of us, and if we are certain, based on the clinical features, based on the history and examination, we are certain that this patient has a particular disease. Say it is a married lady who has come with 3 days of increased urinary frequency, with burning micturition, with fever, and also, so we feel that the clinical likelihood of this patient having a urinary tract infection is very high. So it's a high pretest probability, and especially in the population group where it is common to have a urinary tract infection. So when a pretest probability is so high, that defeats the purpose of having to do the test. At the same time, when we do a urinary test on somebody who has come with a fracture, the pretest probability of them having a urinary tract infection is very low. So that again, the pretest probability is so low that we do not need to do that urine test for that particular patient. So a test is appropriate to be done only when there is a diagnostic dilemma and we are unsure of whether this diagnosis could exist in this patient or not. This question deals with whether the patients who were included in the study were representative of this population. How they recruited the patients was they took 60 consecutive female patients between the ages of 18 to 65 who presented to the ED with a possible UTI. It means they had any lower urinary tract symptoms with or without fever, and this diagnosis was made by the triage nurse. So the triage nurse felt that a urine analysis should have been done. So that they felt was more pragmatic to what would happen in a real life scenario, and so therefore they recruited patients like that. The investigators compared the test to an appropriate independent reference standard. So all patients who underwent this dipstick test also had a urine culture. And so there was a definite growth of pathogenic bacterium, and only then, if there is a growth of bacteria in the culture, they took them to truly have the disease. But those interpreting the test and the reference standard blind to each other's results. So if we see a CT and if we find a space occupying lesion on the lung, and then later on if we look at the chest radiograph, sometimes it becomes what was not visible to us earlier, sometimes becomes more visible. So to avoid that kind of a bias, the investigators who are interpreting the gold standard and the investigators who are interpreting the test under investigation should not know the other's results. So of course urine culture was not available in triage when patients came, but those who were reading the growth plate were not aware of what the dipstick showed. The investigators performed the same reference standard in all patients regardless of the results of the test under investigations. Yes. So all 60 ladies who were included in the study had a urine culture test, and all of them, and based on how many of them grew positive urine cultures, they were taken to truly have disease. So sometimes when it's not possible to do the gold standard test in everyone, if it's an invasive test or if it's a test which has some risks associated with it, people may not choose to do it for all patients. For example, in a patient who has suspected pulmonary thromboembolism, and if you're validating a particular test, and if some people have tested positive for that test, then maybe you may choose to do a CT pulmonary angiogram for all of them. And those who have tested negative, you may just plan to follow them up for a period of maybe 1 year and see if they are not worsening without treatment. And then you may decide that they truly do not have pulmonary embolism. So that is what this question deals with. Whether everyone underwent the gold standard or did only some undergo the gold standard. So here all patients had the gold standard test. So now let's...
Any questions? Any doubts that anybody had? If you all got the article with you, if this has the article, we can just go. Just go back to the questions on this for everybody. So the first question is, when somebody else has done a diagnostic study, and you are reading your paper in your city or wherever you are, you have to see whether the patients which they recruited are similar to the kind of patients you have. Because they might have recruited, you might be sitting as a healthcare staff clinic doctor, and you may say that medical checkup for all patients who are coming, everybody must have urine microscopy, and you do a study. Or you are wondering whether the urine nitrate is a good way to rule out UTI in a medical checkup. But these patients in this study were people who came to emergency department with suspected UTI. They included them. You will say, okay, though this study is very good, my patient population is slightly different. My patient population are asymptomatic young people coming for college admission. So my patient population doesn't represent this study patient. So I can't use this study results directly. Others will just say blanket nitrate test has so much sensitivity, specificity. That we should not. In that situation, it works so well, but it may not work so well in some other situations. Always when you are thinking about should I use this test in my patient, you should go back to the study. Was the study patient similar to my kind of patient? The next question. Now, the new test is a nitrate test. Obviously, we must think whether CMC is using the same dipstick methodology as those people. Because there must be hundreds of dipstick companies, urine dipstick companies. Each company's test may work differently from this particular method. So you must see what CMC does. The next one. Then, the gold standard test is very difficult actually. For suppose somebody says gold standard is the best test for a disease. Let's say for somebody with pulmonary embolism, you will do a CT scan, do an angiogram, and see the pulmonary embolism in it. It's very difficult to do that in real life, very costly test to do. But at least you know that's the gold standard. The new test may be D-dimer, ultrasound, ECG, something, whatever. But in some situations it's not so clear. TB meningitis. Gold standard is CSF culture. But we know that 80% of people with TB meningitis, CSF culture is negative. So it's actually used as gold standard. But world over, many people take CSF culture to be gold standard. And whatever your new test will never be shown to be good because a gold standard is not good. Gold standard is the best test for a particular disease. So nowadays people don't call it gold standard anymore, they call it the reference standard, the best available test. So sometimes now the world has moved, instead of saying CSF culture, now we say if you have clinical features, any laboratory features, AFP anywhere, response to ADT, then we'll call it TB meningitis. So it's a composite gold standard or composite reference standard, against which we are comparing our new test. Then you may ask a question, if you already have a good test, why do you want a new test? Because the new test is much cheaper, much easier. So this urine dipstick is an immediate test. In 2 minutes I can tell you if you're UTI or not. Urine culture will take 48, 72 hours to come. That's why a new test. It is cheap, it is easy. It may not be as good as the best test, but if it's reasonably close, then we say, okay, in the emergency department, you don't have to wait for urine culture for 48 hours, we can just read this. That's why the new test. So in your mind, if you see a diagnostic paper, you must think, the reference standard is obvious, a new test. Is the gold standard or reference standard truly one? And the next question, blinding. Sounds like a bad word, blinding people. But in a diagnostic study, let us say that there's only one small lab in a mission hospital we're working. Urine dipstick is done by Kathy and urine culture is by Vignesh. They are both sitting in the small lab. Ideally, the person doing the urine dipstick should not know the urine culture report. So you must imagine, like, where was the urine culture done? Would it be possible that blinding, though everybody would write the word blinding was performed, one person did not know the other results, you must imagine to yourself whether it was possible that some contamination occurred. Meaning, Vignesh might have asked her, Kathy, what did you find? And Kathy might have asked, this is a little bit, I can't make a pink, is there any pink is nitrate positive? It's slightly pink, I'm not very sure what to call it. Let me just ask Vignesh for the culture positive. That will be a sort of contamination of the blinding aspect. So you must, many people don't know that they're supposed to report blinding in a diagnostic test. So they might have done it but not reported it. So you have to sort of make a judgment call about that. Next one. Now, this is another one. For example, we were doing COVID, during COVID. The gold standard was PCR for COVID. And the new test was an antigen or antibody test. It will come immediately. In casualty, we can't be waiting for 72 hours for the COVID PCR to come, because what to do with the patient, like admit or not admit. So then we had PCR test by one company, okay, that was the gold standard, and we had antigen test as a new test. So we understood the gold standard, the best test was PCR, the comparison was an antigen test. After some time, that company, we ran out of that PCR by that company, so we had to change the PCR to another company's PCR. But to the lay reader, PCR is gold standard. But halfway through, you have changed the gold standard from one company to another company. And we know very well that these things work differently by different companies. So sometimes it just happens during the course of a study, the person providing the gold standard change. So that becomes a problem. Another thing, let us say doing CT pulmonary angiogram to diagnose pulmonary embolism. It's the best test. The new test is D-dimer. CMC hospital has CT pulmonary angiogram. Whereas, and the new test is D-dimer test. Very good. But when you go to, let me say for example, we are doing a multi-center study. Baptist Hospital, Bangalore is part of our study group. They don't have CT pulmonary angiogram. They only have ultrasound of the leg. So they diagnose DVT, pulmonary embolism. Their gold standard or reference standard is not CT. Their gold standard is ultrasound. So sometimes you find multi-center diagnostic studies. Each center had a slightly different reference standard. That is why you should be careful. That should not happen, because that becomes a slight problem. What we didn't pick up, what we didn't do in this study is, when you are planning your own diagnostic study, suppose tomorrow I join first year MD radiology. I report all the CT pulmonary angiogram. I may report many wrong. I may wrongly call some pulmonary embolism as not pulmonary embolism. I may miss some pulmonary embolism and say normal. So when you write a diagnostic proposal, you have to write the experience or expertise of the person doing the diagnostic test. Oh, this is a trained MD radiologist. They have reported more than 20 or 30 CTPA and have been certified in that. And even the dipstick sounds simple, but dipstick to me and you may be slightly different. But the whole idea of dipstick is any lay person without any training, just put that paper in the urine, if it comes out pink, it's UTI, any shade of pink. So perhaps that requires less training. So when you write these diagnostic studies, you must also write the training required. The last thing is, which again is a little different, it's called reliability. Now, suppose two senior radiologists see a chest X-ray, will they always agree? No. That's true. No, I think I don't think. So even though highly trained radiologists come, they won't agree on the same finding on chest X-ray. So for that, when you do a new diagnostic test, you will write in your proposal what is the reliability of that. There's two kinds of reliability. Let's say both of you are senior radiologists. It's called inter-rater reliability. Inter-rater reliability. And the statistics is called a kappa statistic that are produced. This is highly reliable. Even if many different people do the same test, they will always report similarly. Another one is called intra-rater reliability. I'll give you an X-ray today. Tomorrow I'll give the same X-ray. You won't know it's the same patient's X-ray. I'm seeing whether the same person reporting the same thing will report same. So when you do new tests, people will not ask you, but they're looking for these words: intra-rater reliability, inter-rater reliability of either the new test or the gold standard test. Because sometimes we just brush over that, but if you're actually planning to change your practice, then you must think, hey, everybody in the world has now changed. No longer Z-Nielsen test for TB. Everybody has to do gene expert. Why are we doing it? Because it's a better test. But the primary healthcare in Tamil Nadu or Andhra Pradesh or Bihar, that PhD doctor, they're saying very unreliable in doing Z-Nielsen stain. Will he be more reliable in doing PCR tests suddenly? The PCR study was performed in Sweden or Germany, where the technician was a PhD in microbiology. How will that same test be applied in Vellore, Tamil Nadu, Bihar? You may not know how to plug in the PCR machine first. So you have to think about these things. Even though intra-rater reliability was very good in that situation, will it work the same way when I do it in my rural area? So the diagnostic test requires more thinking. So you sit and just think about these issues which people don't. Alright, go on.
So can I ask you a question?
Yeah. About two questions, yes.
So is reliability and variability can be used in the same nomenclature that was the same in this scenario?
No. Reliability statistics is retesting the same thing or two people doing the same test for the same thing. That's called reliability statistics. If it is a yes or no answer, we do kappa statistics. Suppose he is taking blood pressure and she is taking blood pressure. Then it's a continuous value. Then the statistics is slightly different. The reliability is called intra-class correlation, ICC. You see, his blood pressure and he takes blood pressure on me, a minute later she takes, both BP should be exactly same. That is not kappa statistics for reliability, it's called intra-class correlation, ICC statistics. So that is reliability. Validity is what we are talking about today, sensitivity, specificity. Ideally you must talk about both. But when you do critical appraisal, we generally tend to focus only on the validity question. Assuming that the test must be having very good inter-rater reliability, intra-rater reliability, they must have checked all these things before doing these things. The last thing for the lab people, anybody from lab here? So you must ask yourself, when you read the papers in lab, they'll ask some different thing, validity of test. They may mean slightly different. For example, if you're doing a hepatitis C test, our lab can detect anybody more than 1,000 copies per ml. Some other lab can only detect 5,000 copies per ml. So in that lab, if you have 4,000, it will be called HCV negative. Whereas in our lab, it will be called HCV positive. So this is also called limit of detection. At what is the lowest level you can detect in your lab? So in lab, people will sometimes call that the validity of a test. So the same word is used differently in different people. When clinicians use validity, we are talking about sensitivity, specificity, which we'll explain. But lab people are talking about reliability, and sometimes validity is used for the lower limit of detection. You had a question.
Yeah, my question continues with the last statement. So how the scenario will change if the gold standard itself has a less sensitivity?
So then what will happen? Let us say that the gold standard is not so good. Then my new test is actually very good. A new test picks up somebody with TB meningitis, but the gold standards are negative. So you learn from what Catherine is going to teach. Then you say my new test is false positive. Because the best test in the world said it is negative. The truth is the best test goofed up. It should have picked a positive, but a new test picked it up. So it will come as a false positive new test. Then you have to understand that. So you keep on publishing these data, slowly the world will understand. So now initially when Z-Nielsen test was the gold standard and PCR was the new test, PCR picked up many people whom the Z-Nielsen was negative. Now we realize, okay, the Z-Nielsen is very bad, PCR has now become the gold standard. So these things happen over time. But initially when you publish, you have to say, yeah, I think that many of these things which come as false positive are actually when the gold standard. Initially people would not agree with this, gold standard is gold. Now we all understand, okay, the reference standard is also another human test. It will have its own fallibility and we have to accept it. If you go to, there are some methods to overcome this problem, statistically overcome and gold standard makes a mistake, but that's a bit advanced. We can give you some literature. Okay.
These are the results. So in this table, we see the test result of all the different things that were checked in the urinalysis dipstick. And then we calculate the sensitivity, the specificity, the positive predictive value and the negative predictive value. So the test that we are interested in is the urine nitrites. So let's look at that. Urine nitrites is either a positive or a negative test. And out of all the patients, out of 60 patients, 12 tested positive. Now the sensitivity and specificity is calculated based on how many truly had the disease and how many tested positive. So to understand this, you just go to this slide. This is again from the JAMA Users Guide to Medical Literature. So just for us to understand what sensitivity means. So if we take a particular disease, based on the gold standard, we know whether they truly have the disease or not. So sensitivity is another word for a detection rate. So that means out of all those who had the disease, how many tested positive. So that's calculated by true positive divided by all those who had the disease. That is true positive plus false negative. So that's sensitivity. That means out of all those who had the disease, how many tested positive. And specificity is otherwise known as the true negative rate. That means out of all those who did not have the disease, how many truly were negative, truly did not have, how many tested negative. That's what it means. So that means all those who tested negative divided by all those who did not have the disease. That is the false positive plus the true negative. That's sensitivity and specificity. Now, positive and negative predictive value is something slightly different. Positive predictive value is when out of all those who test positive, how many truly have the disease. So out of all those who test positive, that is out of the true positive and the false positives, how many truly have the disease. This is the positive predictive value. And the negative predictive value is again how out of all those who truly don't have the disease, how many test negative. That is out of all the false negative and the true negative, how many truly did not, how many tested negative. That's what that means.
So if you want to just tell them what is the reference standard in this study and what is the test in this, you just write it on top of that.
Yes.
No, you can put it there only, in that table only, just write what is that in bracket.
The reference standard is a urine culture. So if the urine culture grew the bacteria, then they truly have the disease. And the test is a urine nitrites. So if the urine nitrites was positive, so depending on number of people who had it positive, and out of all those who tested positive for nitrites, we calculate the positive predictive value of a test. And out of all those who tested negative, the number of people who had a true negative, based on that we calculate the negative predictive value.
This gives people a time to look at that 2 by 2 table. Does that make sense to everybody? Or is confusing? Because that is the meat of the whole class. If it's confusing, we can go through it again. So if you just look at it, urine culture positive is called disease present. Urine culture negative is called disease absent. Nitrite positive is positive test result. Test negative is nitrite negative. So you have 4 squares. So we just try and see which is a good square. Among these TP, TN, which is good. The true positive is where the urine culture was positive and the nitrite was positive. What is the other good square? False negative, no, that's not a good square. Try again. It is good. What is true negative? True negative is when the urine culture is negative and the test is negative. So that's a very happy situation. Your test is very good. So in these two squares, the test has done very well. When the culture was positive, it came positive. When the culture was negative, it came negative. What is false positive?
False positive is the urine culture is negative, but the test nitrates picked it up as being positive.
So the new test is falsely positive. The patient doesn't have UTI, but the nitrite test picked it up as positive. What is false negative?
They had the disease, but the nitrates didn't.
The urine culture was positive, but the nitrate came back as negative. So what would be a good sensitivity? In sensitivity, what should be low on the sensitivity calculation? Sensitivity talks about this low here. It's a total of this divided by the top. So false negative should be low. So highly sensitive test, false negative will be low. Madhuri, if a highly specific, the specific test talks about this column. So it's the total of this divided by this. So highly specific test, what will be low? What will be low? The specificity is false positive plus true negative in the denominator. The numerator is true negative. If this number should be close to 100%, what should be is very small. False positive should be low. So very good. So a highly sensitive test will have very few false negative. A highly specific test will have very few false positive. In other words, a highly specific test, if it's positive, the patient has disease. A highly sensitive test, if it is negative, the patient doesn't have disease. So we'll come to that in interpretation of the data. So the sensitivity and specificity are understood. But sensitivity and specificity talk about the disease being present or absent. But in the OPD, you are sitting with the patient, the nitrite is positive. In that situation, you want to know, is the patient having disease or not? Right? The sensitivity and specificity don't actually help you in the OPD. I'm sitting in the OPD, nitrite is positive. What do I do with this nitrite test now? That is called positive predictive value. Among all the people, the nitrite, among all those people in whom the nitrite was positive, apologies, I managed to do this again. Oops, what did I do? Maybe trying to move. Okay. So positive predictive value is among all those people in whom the nitrite was positive, how many truly have disease? So a test which is got a high positive predictive value should have very few false positives. So you are hoping that all the tests in the OPD which are positive are truly true positive. You don't want to be telling somebody in the OPD who has, doesn't have UTI, your nitrite is positive, you have UTI. So test positive, we are hoping is mostly true positive. So positive predictive value is good, false positive should be low. Negative predictive values, sitting in the OPD, somebody comes with UTI, suspected UTI, nitrite is negative. What you're really hoping is it's mostly true negative and very few false negatives. So both these values, sensitivity, specificity, positive predictive value, negative predictive, should be close to 100%. But there is no perfect test. So that is the reality. None of the new tests are anywhere close to 100%. And you must also understand, if you say sensitivity is low, that means false negative is high. If you say specificity is low, then false positive is high. You have to understand that flip of the argument. Right? Okay. Go on.
For all practical purposes, what should be a value of sensitivity?
At least more than 90%. Anything less than 90%, that means you are accepting. Somebody comes to the OPD and I'm saying false negative. The test is UTI is a big disease. Somebody comes to a casualty with pyelonephritis, and then the nitrite is negative. No, take metazine and go. Actually, they have pyelonephritis and they go back and die. So that's a big thing. So even then 10%, you may argue that how can you allow 10% false negative? So there's no cutoff point. It all depends on the seriousness of what's happening. So common cold and cough, okay, even if you miss the diagnosis, nothing will happen. But if it's a serious disease, suppose it's cancer, then we want 99%, 99%. Suppose HIV, would you like 1% false negative? No, we don't want even 1%. We want 100% sensitivity, specificity also close to 100%. But you learn that these are not ever possible in real life. It's usually a trade-off. It's the last point to learn. As the sensitivity goes up, generally the specificity comes down. As specificity goes up, sensitivity will come down. So there's always some sort of a trade-off. Very few tests, like HIV tests, I've got nearly 99% sensitive, 99% specific. Everything else is a small trade-off in life. So you have to decide what is more dangerous. False negative is dangerous or false positive is dangerous. Depending on your clinical judgment, you choose high sensitivity or high specificity. Okay?
So now we come to likelihood ratio.
One second, just go back to your previous slide. So now you can understand the sensitivity is for nitrite is, just put in the red box, 47%. Great. And then near 90% is good. No, this one. This 47% is good. Oops, I managed to do something. Well, 47% is not so good. We wanted it to be close to 100%. So if you look at the 2 by 2 table, this is culture positive and culture negative. This is nitrite positive, this is nitrite negative. This sensitivity here came to only 42%. So what is this number? How much? Come on, do maths. 60, 58%. So 58% false positive or false negative? Test is negative, so this is false negative. So would you be happy with that? 58% of the time it's falsely negative. When you have UTI, it's coming negative. Specificity came as 94%. So 94% talks about this. So what is this number here? In percentage wise, 6%. 6% what? False? Positive. See, it's positive, but so would you accept 6% false positive? Somebody comes to the emergency department, nitrite positive. 6% of the time, they don't have UTI, but you land up admitting them and treating the UTI. Now you are a bit hesitant because the patient doesn't have UTI. What have you done? Labeled UTI and treated it. Then are you going on thinking about malaria, typhoid or something else? No. In your mind, this is UTI. So there is a consequence to our false positive as well, because your brain shuts off every other possibility. Oh, that's a known case of UTI. But in fact, it doesn't have UTI, it's something else, or that patient doesn't have it. So everything has a consequence, so you have to sort of live with that. Now, Kathy is going to explain likelihood ratio in a second. But you must understand one thing, sensitivity and specificity doesn't change from place to place. So the same nitrite test is done in CMC or done in Chittoor or in Ranipet hospital, you get the same sensitivity and specificity. Okay? But the sensitivity specificity don't change. What? Sorry? Even the population changes, sensitivity and specificity don't change. But just go back to the previous slide. See this one. Or the next slide, sorry, the next slide. This one. What does change is positive predictive value and negative predictive value. Suppose I go to a casualty department and people suspected UTI. Many of them are likely to have UTI because you are selecting or you are not doing road traffic accident, you are not doing urine nitrate. Somebody got fever, dysuria, flank pain. So the high chance even without doing a test that they have UTI. So that is a place where the prevalence of disease is high. Why is prevalence high? Because you are selecting people most likely to have UTI. In places where the prevalence of disease is high, positive predictive value will be high. Suppose I take medical students who came for checkup before joining. They don't have any symptoms. If I go and do the same nitrate test on them, the positive predictive value will be low. That's what changes from place to place, the positive predictive value. Similarly, negative predictive value. Suppose I go to a commercial sex establishment, red light area, and I check HIV. Then the test will be very good. Suppose I go to school children and check HIV. Then the negative predictive value will become very low. It will become a lot of people unnecessarily who don't have HIV. So even the HIV test which has got 100% sensitive, nearly 90% sensitive, 90% specific, will become many people which don't have disease. So let's do the simple mathematics. I take here. I take 100,000 school children. Can you all tell me the answer to this? And I have a child who is HIV positive. They were simply school health checkup. Raja did school health checkup on 100,000 school children. One child's HIV came positive. HIV sensitivity is 99%. Specificity is 99%. Does the child have HIV or not? I'll give you all 1 minute time. You can use a pen and paper. You can think and tell me the answer. This is what you get in real life. You know that test is positive. Does the child have HIV? So I'll just put, what do you think is the prevalence of HIV in school children in Tamil Nadu? 0? What do you think? 4%, 0.1%, so we take 1% as an average. Just saying 1%. So we have 100,000 school children. What is 1% of 100,000? 1,000? That means 99,000 won't have, correct? 1% prevalence is what we have a clinical guess. So whenever you do a test, you always have a pre-test probability. You have a guess in your mind. That's called pre-test probability of a disease. You have some guess in your mind. What is the chance this person has disease? Your school children who are just coming free in school, you're thinking 1%. You may think less or more. So there are 100,000 school children. That means 1,000 will be having HIV. Correct? And 99,000, is it 99,000? Correct? So this should be HIV negative. What is the sensitivity? I told you, no? 99%. So how many will it pick up? 99% of 1,000 is what? 9,990 or 9,900? 990? Correct? Or am I wrong? 990. What is the specificity? 99%. What is the ulta of specificity? What is the inverse? The 2 by 2 table, you remember? Specificity, that column? You forgotten? There was a 2 by 2 table like this. This is 99%. What is this? False positive. So what is the false positive rate? 1%. So among that 999,000 people who don't have HIV, how many will the test falsely be positive? So false positive rate is 1%. What is 1% of this? Sure, eh? I'm not good in maths, correct? So the test is now totally positive in, correct? Among the 100,000 children, The test will come positive in 1980. How many of them actually have HIV? 990, which is 50%. The pre-test probability was 1%. Even a test which has got 99% sensitive, 99% specific, post-test probability is only 50%. Would you be happy if it was your child? Magic, school teacher calls up, by the way, your child has HIV. So for COVID, what happened? The test was not even 90% sensitive or specific, PCR. Yet we told people COVID PCR positive, you are quarantined for 3 weeks, 3 months till you become negative. All the COVID people negative at all, you can roam around freely. So actually it was quite useless because we picked up even worse than this way. But if you explain all this to public health officials, we cannot go down this road. Very complicated on this. But the truth is, if you do a test with very low pre-test probability, even a best test in the world will be quite useless. Would you be happy to tell in the school 50% of the time will be wrong? Why or not would you label a child? For life, the child will be scarred. For the child, maybe HIV positive. Then imagine the parents, what they must be doing. So all this kind of, you can imagine the social implication of telling a child wrong. So that I'm trying, so the like sensitivity and specificity generally don't change from place to place. Positive predictive value, negative predictive value change from place to place. So what Kathy is going to explain is, then how do I use it in my clinical practice? That's called likelihood ratio. I have given you the mathematics of likelihood ratio here. It's not calling it likelihood ratio because people get what is this likelihood ratio and get worried about it. But to answer her last question, I told you sensitivity and specificity generally are same all over the world, whereas positive predictive value, negative predictive value change depending on the prevalence of disease. But for the lab people, you must also understand, where does sensitivity specificity change? Suppose I did the test on patients with advanced cancer. Let us say the gold standard in a test. The gold standard was people with, I took people with very likely to have advanced cancer or whatever, and the new test was a liquid biopsy. That is, you take a blood and see whether the blood has got cancer cells floating about in it. So if I do a blood test and it comes positive, then it's called liquid biopsy positive. Is that okay? So that's now the new hot test now, liquid biopsy. Take a blood and see the cancer cell in the blood. And the gold standard is biopsy positive. And gold standard negative, biopsy negative. It so happened that most of the people in the study had advanced cancer. In this situation, okay, the sensitivity and specificity are likely to be high. We're not talking about prevalence. This is a slightly advanced topic. Do not get confused about prevalence. Now, in real life, I have a group of patients. Let us say urology, this study was done in Harvard, but most of their patients turned out in the end to be having advanced urological cancer. But you want to use a liquid biopsy in your situation. What you will find is that most of your patients have not advanced cancer but early stage cancer. And this is the new test, positive, negative. You will find your sensitivity is less, your specificity is also going to be less. So sensitivity and specificity generally don't change world over. But if that test was done on people with more advanced disease, then you may get a slightly lower sensitivity specificity than what you are expecting. Otherwise, general rule is sensitivity specificity you can use from any test in the world you can apply to your population. Unless your population tends to have less severe disease as compared to those kind of disease. So, one of the tricks of lab people when they're starting a new study, I'm not making fun of lab people, to choose people with very severe disease and do the new test. Because the new test will look very good. But in real life, the doctor will be applying to people with much less severe disease, then the sensitivity test may not work. It's not prevalence, it's severity of the disease. They have disease. But the more severe the disease, the sensitivity specific of the initial test likely to be better. Is it okay? Confusing very good. Okay, so now we'll go back to having understood this. This everybody understood now? Pretest probability came from where? From your knowledge, from your guess, from your judgment. You're a doctor, you can make out a guess what the chance of a school child having HIV. If you say 0.4%, you can redo the maths. How do you redo the maths? 0.4 out of 1000 will become 400. Correct. And this will become 99,600. And you can redo the same story. So you can vary your pretest prevalence depending on your guess. And you land up with a post-test. You understood how we got 50% post-test? 50%, this is 50%, 990 out of 190, only 50% of them truly have disease. The other 50% don't have. Did I confuse anybody? Pre-test prevalence comes from your guess. Using the sensitivity specificity, we came to a post-test prevalence. This is maths. But if you don't like this maths, if you like to use a formula, that's going to be likelihood ratio. So that's what we do. You can rub off all these things. Oi. I won't rub off it. There's a likelihood ratio of calculation that's below us.
Just to understand the likelihood ratio, the likelihood ratio is actually a ratio between the true positivity rate and the false positivity rate. The false positivity rate is not the same as sensitivity. Sensitivity is the true negative rate. So that means out of all those who did not have the disease, those who tested, out of all those who don't have the disease, those who tested negative. So the true negative rate is the sensitivity rate. But here the likelihood ratio is a fraction between true positives and false positives. That means out of all those who had the disease, how many of them tested positive, and you divide that by out of all those who did not have the disease, how many of them tested positive. Okay, so that's how we calculate the true positivity rate and the false. So the fraction between the two gives us a likelihood ratio. And similarly, a negative likelihood ratio is the false negativity rate divided by the true negativity rate. So that is, out of all those who did not have the disease, how many were falsely negative, and true negativity rate is out of all those who had the disease, how many actually tested negative. Out of all those who did not have the disease, how many tested negative. So that's what tells us. So again, the false negativity rate is just the remainder of the sensitivity, and the false positivity rate is the remainder of the specificity. So we can just get it as 1 minus sensitivity or 1 minus specificity. We'll calculate it for our test in the next slide. So
just to understand, this is why are we doing this new maths now, likelihood ratio? The main reason is to go from pre-test probability to post-test probability. We want to use our Vellore pre-test probability for a test and come to in Vellore itself what will be our patient's post-test probability. That is why we are going to learning this new formula of likelihood ratio. So, in simple English, a likelihood ratio in people with disease, how likely is a test positive, divided by in people without disease, how likely is a test positive. In people with disease, always on top. People without disease in the bottom. How likely is a test positive among people with disease, divided by how likely is a test positive in people without disease. So the formula is always easy to remember. Just see always this likelihood ratio formula. Sensitivity is always on top, specificity is always below. Even if the test is negative also, sensitivity is on top, specificity below. So likelihood ratio always will have sensitivity on top and specificity below. If the test is positive, then you put 1 minus specificity as the formula for calculating this strange entity called likelihood ratio. If the likelihood ratio if a test is negative, again sensitivity on top, specificity below, but the 1 minus goes on top. Very easy to remember these formulas. We'll do that. What was the sensitivity in our patient? 42%. What is the specificity? You remember from the previous slide? 90? Sorry, 94%. So 1 is also 100. If you can put it as 0.42 and 0.94, then 1 minus. Or you can put it as 42%, 94%, and this is 100 minus. So what will that come to? 42 divided by 6, 7. So the positive likelihood ratio came to 7. Negative likelihood ratio, again 100 minus 42 divided by 94. Anybody else likes maths? 58 by 94, roughly about 40%, 0.4. 0.6. So now we'll have to see what is the use of having calculated this 7 and 0.61.
Now once we know the likelihood, this is the normogram that is given to us by scientist Fagan. So this is an easy way for us to look at visualize the post-test probability. So here we connect the pre-test probability, which is just an assumption that we have of how likely the patient is to have the disease based on the population prevalence and based on the patient's clinical features. So say, let's just assume in this example, we feel that there could be a 20% prevalence. And then after the test, we are able to calculate a likelihood ratio of 25 or say maybe 30. Here we are able to calculate a likelihood ratio of 30. That means if this test was positive, this patient is 30 times likely to have the disease. So that's what it means. So if you connect these two line segments and if you extend it, that will intersect this line, and that gives us the post-test probability. So this test is so good that the likelihood ratio that we are able to get from this test being positive is about 30. So the post-test probability has gone up. From a pre-test probability of 20, it's gone up to 90%. So the likelihood ratio depends only on the test characteristics. So which tells us that if it is positive, this patient is likely to have this disease about 30 times, 30% of the likely to have it around 30% of the time. 30 times if you do the test. So that's how we get a post-test probability from here.
Okay, so everybody understood that. So in your situation in the OPD, somebody comes with burning urine. Do they have UTI? So as a doctor, you make a judgment. I think 20% chance of having UTI. Without having done any test, just looking at them. That is your pre-test probability. You do the test. It is a nitrite test. And instead of asking the lab for the sensitivity and specificity of nitrite test, you ask them, please give me the positive likelihood ratio. Please give me the negative likelihood ratio. So for this example, on the board there, they are given a likelihood ratio of 20. So how do I use this in OPD? I can't be doing maths in OPD. But we can use this normogram. The pre-test probability was 20%. This lady who walked in with burning, I thought 20% chance of UTI. The test was positive. Nitrite test came positive. The OPD nurse said the nitrite is positive. I know the likelihood ratio is 20%, 25 or 30, whatever, the positive likelihood ratio. So I take out this small chart and I connect the lines. How do I connect? I connect 20% pre-test probability. I connect it with this line of maybe the likelihood ratio, let's say 30. I just connect it and I keep going, and then it tells me the post-test probability. After doing a test, now I am 90% sure that she has UTI. Will I treat her now? Yes. At 20% I am not happy to treat. So now my test has been very useful for me. Let us use the same example here. We got a likelihood ratio of 7. So somebody comes with a burning sensation in urine and is looking very well. Pre-test probability, let us see 20%. The likelihood ratio we got was 7, which is somewhere here. This is called likelihood ratio. So we connect 20% with 7 and we just go, okay, my line is not very straight. I've got some disorder. But the post-test probability is somewhere around 70%. Now I must decide, at 70% do I want to treat or not treat? Right, that's a positive likelihood ratio. The negative likelihood ratio we got is 0.6. Now the patient came, the same patient, the nitrite test is negative, so the likelihood ratio is 0.6. So this is 1, this is 0.5, 0.6 is somewhere here. So I must magically connect those two lines. Okay, my line didn't draw very well, maybe it comes somewhere there. Let's say 8%. So now the patient in the OPD who is having burning sensation, the dipstick is negative. What is the probability they still have UTI? About 8%. So now we are using our own clinical judgment along with the test to come to a new judgment. So this is also called the your prior knowledge. This is the current knowledge, the test being positive or negative. And in science, this post-test probability is also called posterior knowledge. Sounds a bit confusing, but you just have to get used to this word posterior knowledge. Your prior knowledge, which comes from your clinical judgment, you're using that with the test being positive or negative to come to a new judgment. This is also called Bayesian thought, Bayes. He's a priest, a 17th century priest who said, all of us don't make judgment just based on tests being positive or negative. We also think about what we thought before the test. We usually marry all this. So somebody says something, we always interpret in the light of what we already believe. So that's called Bayesian thought. There's something maths behind Bayes. But there's a likelihood ratio really comes from this Bayesian principle. So actually in the West, if you go there, many people have this is called Fagan's nomogram. They have a copy of that Fagan's nomogram with them on their phone. And the test is positive, quickly calculate the post-test probability and decide this. Because actually, after some time it becomes in your mind, you know. Simpler interpretation. I cannot understand Fagan, all these things I can understand. What is the simple interpretation of likelihood ratio, positive likelihood ratio, 10 or above means people have disease. Any test with a positive likelihood ratio of 10, that means any test positive is disease positive, generally. A likelihood ratio, a negative likelihood ratio close to 0.1 means the person doesn't have disease. This means a test positive, disease positive. Test negative, you can say disease negative if the likelihood ratio is 0.1. That means what is in between 10 and 0.1? 1. Any test with a likelihood ratio of 1 is practically useless. It neither helps you to confirm your diagnosis nor rule out a diagnosis. So that is the interpretation of likelihood ratio. Sometimes the people put on a scale. 10 is here, very good. 0.1 is here, again very good. 1 is here, no use. So the closer any positive test is to likelihood ratio of 10, we are very happy. Any test with a negative likelihood ratio close to 0.1, we are very happy. And a likelihood ratio of 1.5 is not very good. A negative likelihood ratio of 0.9 is not very good. Compared to that, 0.3 is better. Of course, 0.1 is best. I'm just trying to give a general idea. You can't remember any of the maths, so this is how we have to do it. Okay. That's okay.
So here we have calculated the likelihood ratio for this test. So it was around 7 point something. So this is using an online calculator. This is the University of Illinois Chicago calculator. It's available on MD Calc also. If you put in the sensitivity and specificity, that creates the 2x2 table for us. Or if you put in the 2x2 table, it will calculate the sensitivity and specificity for us. So here we see that out of all those who, out of the 60 patients, 36 had urine culture being positive and 24 had urine culture negative. So those are the true disease present and disease absent. And out of all of them, 19 tested positive for nitrites and 41 tested negative for nitrites. So here, then therefore we can calculate those who are test positive and test negative based on out of those who are disease present, and test positive and test negative out of those who are disease absent. So now, when we calculate the likelihood ratio, we got the ratio as 8. So here again, this just elaborates the same thing in the 2x2 table. So, the blue line denotes the positive likelihood ratio. So in this patient who is elderly, who is diabetic, and who has increased frequency of micturition for 3 days, although the pyuria is not showing anything, we